Thank you, everybody, for attending today. I'm not so sure how innovative this is. This may be familiar territory for many of you, but for many of you, it may be innovation and new areas. So hopefully we'll have lots of time for dialogue, questions, and discussion. Hopefully lots of time to do that at the end, okay? So we'll try to do that more towards the end. So the objectives you had on the flyer that went out and about, so these are the kinds of things I'm going to try and cover today, is to really try and clarify some of the terms that are out there around patient activation, empowerment, self-management. What do they all need? Because I don't know about you, but I'm kind of lost in these terms. To really start to speak to what are we talking about when we're talking about patient activation and self-management, and try to define what that might look like for cancer self-management within a cancer program, and what are the kinds of transformations that we might need to think about doing, and that there's efforts underway within the province of Ontario towards better self-management, patient engagement, patient activation as part of routine or systematic care, as standard of care that may become very important. So many of you may be familiar with some of these reports that came out about the Quality of Cancer Care Institute of Medicine reports, as well as the American Society of Clinical Oncology, the director of that particular ASCO group, suggested that when we start to think about personalized cancer medicine and genomic medicine, one of the areas that we've actually missed when we start to think about personalized cancer medicine is the whole area of patient engagement. And so he actually suggested that we need to start to think about patient engagement as the fourth revolution of personalized cancer medicine, as important as big data analytics and as important as genomic medicine or gene therapy or immunotherapy. In addition to that, the Delivering a High-Quality Cancer report suggested that patient engagement was seriously of poor quality across much of the cancer system, and that we really needed to make large transformational efforts to move patient engagement front and center within routine cancer care, and we need to have a better understanding of what that means. Our own personalized cancer medicine strategic directions suggest and include that strategy A is to empower patients as partners in care. So that is also something that's fundamental. But even before all of these reports came out that were very specific to cancer, Leonard Kish, when he was thinking about chronic disease self-management or any particular chronic disease, really spoke to the whole issue that an engaged patient or an activated patient is really the blockbuster drug of the century, and it almost should be thought about as malpractice to withhold it, the same as it would be malpractice to withhold a beta blocker from a patient who suffered a myocardial infarction. So those are the kinds of reports that are coming out about the importance, but there is much to be done around cancer self-management and better understanding of how do we do this, and how do we do this within a rapid episodic ambulatory cancer program type setting. From the patient's perspective, I don't need to tell you that they're assuming greater and greater responsibility for care and chronic disease management. In cancer, they assume even more issues related to more complex cancer treatments. And this is from the patient's perspective again. So better drugs, targeted therapy, all the kinds of things that are happening within the cancer arena help us to live longer and well despite the cancer. But of course, that means that they have to figure out how to use them correctly, how to actually reorganize their day to accommodate all the chronic issues that they might be facing with the cancer diagnosis and treatment, and of course the acute issues as well. So we sometimes underestimate the amount of reorganization that cancer patients need to make in their daily life to accommodate the self-management tasks that they need to actually take on. And there's actually newer research that's coming out about that we need to think about this in terms of that we may actually be adding treatment burden to patients by the amount of tasks and behaviors and issues that they have to manage because of the complexity of cancer treatment. So we do need to start to think about that. In addition to that, of course, the whole issue of navigation and coordination of multiple sectors, multiple silos of systems that patients cross in order to get services and care across that whole of the continuum and the different phases of the cancer continuum. And of course, all the issues around managing new devices, new technology, and of course all the symptoms and multimodal side effects or effects of cancer treatment and cancer itself as well become incredibly important. What's particularly important is we think about, so patient activation, patient engagement, all of these kinds of terms, self-management, have been around for a very long time for traditional chronic disease, such as arthritis, such as diabetes, etc. But when you start to think about, the literature suggests that one size does not fit all, so that the same chronic care programs that have been designed for traditional chronic diseases, such as those I've mentioned, may not necessarily fit for cancer populations. So some of the core skills in those programs will be quite applicable, but many may not, because when we start to think about cancer, it is unlike other chronic diseases. There are much more complexities around the three main tasks of self-management that need to be handled, which is medical management, emotional management, and role management. So just under medical management alone, the complexities that I spoke to, some of the issues of the permanent pathological alterations that can occur into cancer survivorship as part of treatment modalities, the whole issue of needing to manage behavior to reduce late effect risks and potentially influence longevity and survival becomes incredibly important. Weighing complex evidence for decision making. So there's many more decisions, many more complexities that may be important to think about when we start to think about patient activation in a cancer population. In addition to that, all the role management issues in terms of post-treatment survivorship, return to work, as well as straight through to the whole issue of uncertainty, emotional and existential distress that are part and parcel of the experience of living with cancer and coping with cancer as well. So really cancer, when we start to think about it, may need a little bit of a different tailored approach to think about chronic disease self-management programs and how they might or might not apply to this particular population. And I thought these words were quite apropos from the Emperor of All Maladies, who suggests, again, that sometimes for cancer patients, and cancer patients speak about this all the time, that they actually feel very, very overwhelmed by all the potential tasks and issues. We think just about those three main tasks and all the issues that they have to face and address and self-manage, it becomes quite overwhelming. So we do need to think about that as we move forward. So I don't know about you, but I sort of get lost in terms because we hear a lot of terms being tossed out. Empowerment, we hear the term empowerment, we hear the term patient activation, we hear the term patient engagement, and I've looked extensively at this literature, and I'll tell you, people assume that these terms are synonymous, that they're actually the same term. So even things like patient engagement, patient education, they assume is the same as self-management. I'm going to speak to that and drill down and define that a bit further for you. But here are some of the terms, and I wanted to give you some of the definitions, and I'll drill down to a couple of these in a bit more depth. So patient education was defined by Cancer Care Ontario as follows, and I'm sure we have our own patient education definition here, which I should start to include on this slide. Again, a distinct and definable activity to support learning and behavior for participation in care. Engagement tends to speak about the actions individuals must take to gain better benefit from their health care, and often patient engagement and patient activation terms are used as though they're the exact same thing, and they're actually not. And often what we see with patient engagement, it tends to be that overarching focus of an organization about engaging patients within planning, meetings, etc., to direct where cancer care is going to go. It doesn't necessarily mean patient engagement in terms of self-management activities or behaviors to manage their illness. So that term is often also misinterpreted. But certainly patient activation is a term that's more focused on an operational aspect or a very specific aspect of patients' abilities to manage their disease and illness. So we tend to be moving more towards this term patient activation in most of the literature. Empowerment, of course, is described as a process, and John Avery's here who's trying to sort some of this out as to what really empowerment looks like and what it really is all about, so I'm not sure we even understand that that's the right definition yet. And then, of course, patient activation is really about the knowledge, skill, and confidence. So it's three main attributes that we think about when we think about patient activation, that patients hold around how to manage their health or their health care. And it's a very specific term that's used a lot in the literature, and it's been used a lot in the UK, and there's measures to actually measure it. Whereas self-management is the actual specific tasks that the individuals must take to live well with illness, and that includes, of course, having the confidence to deal with those medical management issues, the emotional management issues, and of course the role management issues as well. So So just to drill down a little bit more on patient activation. So a lot of literature is suggesting that we move away from the term patient engagement because it's such a large conceptual term and it's really more about a system level. That we need to think about more around patient activation, which is really from a clinical perspective is probably more apropos because it really does speak to us being able to influence and facilitate the patient's knowledge, skills, and really abilities to self-manage. So it's that sort of one piece of behavior or cognitive aspect, behavioral concept that includes patient involvement, patient participation, but it's really all about patient participation and engagement in their self-management behaviors or the tasks that they need to actually take on to manage an illness effectively. It is described, as I already said, the knowledge, skills, and competence, and of course there's lots of literature that suggests a positive change in activation is related to a positive change in self-management behavior. So it's the term that's more closely aligned to self-management in terms of being able to measure it, to be able to make a difference in it, et cetera as well. This is the measurement of patient activation. I only wanted to show you this, and we've got a study right now that we're looking at this particular tool and whether it actually scales well to cancer populations, as well as we've actually tested this in our patient-reported outcomes project and have shown that we can shift patient activation by really working with patients around self-management skills and tasks. But I wanted to show you this so that what's happening in the US and many other places is the first questionnaire or the routine questionnaire that patient gets asked is what's their level of patient activation. And this is what they're asked to actually rate themselves as to where they sit on these 4 levels. A number of items are asked again. So it actually says that at level 1, the patient feels quite disengaged and overwhelmed. They really don't feel that they can take any action related to their illness. Their knowledge is low. They really feel that the doctor's in charge of their health. They don't even know or recognize that they can play a role in taking actions around their illness or what their role is. They assume that that's by virtue of only the authority of the clinicians or the professionals. Whereas level 2, so the assumption is there's an evolutionary process that we can move patients, we can see where patients start, and we can actually personalize our support or our coaching or our facilitation based on where that patient starts on this particular continuum. So patients who's at the highest level of level 4, where they're really actually adopting behaviors quite easily, they're a person who's actually able to adopt behaviors, they are very much engaged in managing health, they've been managing their health for a very long period of time, recognizing that of course that cancer creates a new repertoire of behaviors that will be necessary for them to adopt. It still means that they probably have some skills and competence to manage their health. And so you can quickly move them and work with them around the level 4. So you wouldn't necessarily need to give this person a whole lot of information around how to manage their health. They're already partway there and you would tailor your information accordingly. In the middle, of course, is everything towards becoming aware and struggling with that and moving towards an increasing level of activation. So we're doing some cognitive interviewing on this scale just to see how it does play out for cancer populations because it's only been tested particularly in chronic diseases such as diabetes with the traditional chronic diseases. What we do know in those studies that have been done, because this has become a standard of care in the US for customizing care within US organizations, not cancer organizations, for chronic illness. And what they do suggest is that these are the results that they're getting from the level of patient activation that the patient presents with. So the less activated patient tends to be the patient who's readmitted to hospital more frequently. So this is really important for us when we start to think about system change. The less activated patient is more likely to experience a medical error. So you can see those percentages there, 35%. 41% of less activated patients have poor care coordination. 48% suffer a health consequence because of poor communication. And again, the lowest or less activated patient at that lowest level of activation loses confidence in the healthcare system and actually starts to feel almost like there really isn't anything I can do to manage my health, so why bother? They really start to be quite disempowered. John will get me one for that one. Whereas self-management is really about this particular definition. So I wanted to just speak to that a bit and a little bit further to just show you the difference, because I'm always surprised when I give this talk that people think patient education is self-management. While patient education is fundamental to self-management in terms of knowledge and abilities around to managing illness. It is not the same thing. I'm going to speak to that in a moment as well. So self-management is defined by the Center for Advancement of Health as involving, it's really engaging activities that protect and promote health, monitor and manage the symptoms and signs of illness, and again, managing the impact of illness on functioning, emotions, and interpersonal relationships, and adhering to treatment regimes. So that becomes really important when we start to think about, when we think about our patient population, do we start to see that that's how our population is actually enacting? Are they actually behaving in that way? It helps us to understand, are we actually contributing to their ability to self-manage? So it's a very good definition from that perspective. But self-management isn't something that necessarily occurs on its own. So all of the literature would suggest that actually self-management is a collaborative process. It occurs in collaboration and in partnership with a clinician. And so when we start to think about system change, we start to think about that. Really, we need to think about, are the clinicians skilled and knowledgeable to actually facilitate and support patients in their self-management behaviors? And it's described as the systemic provision of education and support interventions, again, to increase patient skills and confidence in managing their health problems, including regular assessment or progress and problem goal setting and problem-solving support. So that will make a lot more sense in a moment when I show you the characteristics of a patient who's an effective self-manager. This is not self-management. So these are from some of our own research that, again, we make this assumption that patient education, which tends to be about dissemination of knowledge and knowledge change, will translate into patient self-management behavior. And if a patient's at the highest level of activation, that's possible it will, because they will actually have some of those skill sets to be able to take that knowledge and that information and actually work it towards adopting particular behaviors. But for many of our patients, this is how they feel. And this is recent data, that they feel that they're getting all this information. You've probably heard patients say, I really don't have the information I need to understand what's happening to me. And you just spent the last hour providing them with all kinds of education, all kinds of information about their illness, all kinds of information about how to manage their disease, but yet they say to you, I don't know what to do next. I don't really understand what's happening to me. It's because they're not absorbing information. They don't know how to take that information and turn it into action to improve their health or to manage their health or the issues that they're facing as part of their cancer diagnosis. I'm just so happy to see Janice sitting there. So the difference for patient education and self-management, as we start to think about self-management, these are the 5 core skills that need to be supported by a clinician or whoever is a partner for that patient, that they need skills around problem solving. They need particular skills around decision making, because they need to make the daily decisions to say, how would I adjust my behavior today? So for instance, as a pragmatic example, patients who are really significantly fatigued due to the cancer, they need to be able to make those decisions on a daily basis. Do I exercise this amount today? Do I exercise this amount today? How do I actually know that I'm actually exercising too little, too much? They're making those kind of daily adjustments and decisions in their behavior all the time. The same kind of thing happens with some of the treatment modalities as well. Will I be adherent to these medications today? I'm a little bit concerned about being adherent because I'm quite sick with these medications. So they're making those daily decisions all of the time. We need to support them to make them more effectively. Utilizing resources such as peer support, navigation systems, and of course, being able to take action, know what actions they are, to adopt those behaviors as well, and of course, being able to form a client healthcare provider partnership. What that really means is being able to communicate effectively the tempo and trends of the illness, to be able to say to the healthcare practitioner, I'm really not doing as well in terms of this fatigue or this pain problem, and here's what it's like in terms of over the last week. Luckily, we have patient-reported outcome systems that are helping us to do that now in our centers, but those things become important. So these are the characteristics just in terms of what an effective self-manager, and you've just heard me say that many of the core skills that we need to teach patients to manage to become effective self-managers are sort of embedded within this long list, so I won't go through them in great depth, but they do need to still learn about their disease. So absolutely, patient education is still important. They still need information, they still need to understand the disease, they still need to understand the treatment modalities and the effects that they're going to experience, but they also need to develop these kinds of skill sets. And I'm going to show you this in a conceptual diagram in a few moments. Maintaining emotional and psychological balance. We hear over and over again patients say, I really got good information about the side effects of treatment, how to manage that, but I really don't know how to muster the coping skills required to manage this illness. I really wasn't taught those types of self-management skills. And so I'm still struggling with the uncertainty, I'm still struggling with the emotional and existential aspects of dealing with cancer diagnosis. So all of those become important, but we really focus in self-management is on self-efficacy of the patient's confidence and ability to do something. And actually asking them at the end of a teaching session, do you feel confident that you could take the behaviors or actions that I'm describing to you to manage your fatigue, to manage your pain, to manage your symptom side effects, or whatever they might be. So it is a collaborative process, as I've said. This is just another slide similar to what I've already said. Being able to choose among treatments, being able to identify and set goals. So that's happening in the collaborative process that we're working with those patients to set goals around their behaviors. We're helping them to develop an action plan and very specific actions that they can take to manage a particular problem. And then, of course, find ways and solutions with them about how to overcome barriers to enacting the particular behavior. Because again, they need to think about, how do I incorporate this new behavior or this new strategy within my daily day? And if you think about the complexities that I raised earlier, that can be very, very challenging. They really need to reorganize a lot of things within their daily life to manage these issues. So I just wanted to show you, this is a very, very one-picture slide of some of the research we've done here, showing that, in fact, when you measure things like if goal setting and action planning and all of those aspects of problem-solving, skill teaching become the important aspects of what we should be doing in an ambulatory cancer setting, then what you see from our data, and this was in, you can see the numbers along the top, have a good group of mixed cancer populations along the top, 428 patients, that what you can see is actually, again, if this is a 1 to 5 scale, and 5 is, I would expect for high quality, we should be in the always range, or the 5 range. And what you can see across the prostate, breast, and populations, we have some issues, we have some gaps in terms of our ability and what we're doing in terms of really fostering or facilitating self-management, so that they're really quite low into some of the times they're getting some help with goal setting, some of the time they're getting some help with problem solving, but really most of the time the quality of our self-management support with ambulatory care is needing some work. So why does it matter? Keep an eye on my time here. Because what the patient does in regards to managing their health can make a difference on survival. Not only in terms of the life-threatening acute toxicity aspects of cancer treatment and managing those effectively so they're not ending up in the emergency department or with life-threatening emergencies or life-threatening situations, but also when we start to think about cancer survivorship and even thinking about those behaviors earlier on during the acute phase of treatment, how much are we working with patients around what they can do to start managing their health, really from the day of diagnosis all the way through their whole cancer journey. Into survivorship. And there's lots of data suggesting, of course, things like physical activity, certain health behaviors make a huge difference in terms of longevity, survival, and risk of reoccurrence, the cancer coming back again. So it just become important. Our own review, supported by Cancer Care Ontario, clearly showed that self-management, patients who actually have any exposure to self-management programming or self-management interventions have better outcomes in these particular areas. Lower symptoms, severity, better functioning, improvements in quality of life, reductions in depression, reduction in anxiety, and of course increased participation in those healthy behaviors such as exercise as well. This particular review is on the Cancer Care Ontario website, so you can get this particular systematic review of self-management. And I just wanted to show you, I know I've spent too much time on this, but basically what we found in the literature, so as I said, there's certain skill sets that the clinician that the clinician and patient are working towards the core elements of self-management or self-management education. And I have used the term self-management education, even though I'm not really speaking about patient education in its pure sense of the word. And the reason we did that is because it's a term that we're used to using in cancer programs. We think about education, we think about patient education, so if we can just slightly shift that now towards more self-management education, we'll start to think about that. But I wanted to just show you that in terms of the review that we did, what we found in most of the self-management programs or interventions in cancer populations, few of the core skills were emphasized that have been shown in all of their chronic disease literatures to be fundamental to actually better outcomes. So there is that sort of causal relationship that we're trying to show in this particular model, that these are the kinds of skill sets, the core elements of self-management education. So again, the collaborative partnership, I've already spoken to those, goal setting, action planning, supporting problem-solving skills and daily decision-making, supporting patient development skills. What's particularly important when we start to think about cancer is, again, every type of cancer, every type of treatment is going to require a bit of a different tailoring approach in terms of the specific self-management skills that are disease-specific or phase-specific, in terms of whether they're in the acute phase, whether they're in the survivorship phase, that need to be thought about. And of course, all of it's about coaching, and you can see in the skill sets that means for clinicians that there's a set of skills, patient-acquired skills that need to happen, but the educator actions are the thing that are up on the top. So when you start to think about your own knowledge and skills, University Health Network now does have programs such as Choices and Change that you can participate in, and they're great. I've been to them, and I need to get to the practice sessions, and actually use them with patients. But you can kind of see there's all kinds of coaching abilities, coaching skill sets, knowledge and skills that you require as a clinician working with patients in self-management behaviors. And what will happen is these are the kinds of things you'll start to change for that patient. And all of that then translates into that kind of better outcome, the better health that you saw in that systematic review or literature review that I showed you. This model is being used within Cancer Care Ontario to start to lead towards strategic directions for transforming care towards self-management in regional cancer programs. So the other benefit and advantage is that there's been cost savings shown from chronic disease self-management. So patients who participate, and this again was more in the typical chronic diseases, but this is a review that showed that just participation in chronic disease self-management program for one patient can translate into a savings of $350 per 10 patients for the healthcare system. And the whole healthcare savings in terms of billions of dollars around chronic disease self-management. So that's why there's such a push in all other traditional chronic diseases to move towards this effort, and of course there's that push within cancer as well. So there is cost savings, and there's definitely cost savings even from the patient's perspective, from a societal perspective, because hopefully they stay out of the emergency department. They're able to stay out of the hospitalization if we actually do a better job of helping them to self-manage the side effects of cancer and treatment. So where to begin? Let's just see how we're doing time-wise. So one of the things that's really incredibly important to think about, and I want to make sure we have good time for conversation, is that we need to think about that in order to embed self-management within current and future, it's necessary to make shifts in both culture, infrastructure, how we organize care, how the model of care is organized. Are any of you working within the proactive models of care, the colorectal group here from proactive models? No? Okay. We're going to be doing some work around that to actually embed the self-management piece in there. So it really does take sort of a whole system approach to actually think about making self-management part of everyday or standard of care within an organization. And some of the first things, as I said, was the shift in culture. So a paradigm shift, first and foremost, time for a paradigm shift. Moving from that traditional care model of assuming knowledge drives change, patient education alone without really focusing on self-management, to assuming that knowledge and competence drive change in behavior. The focus is on that change in behavior. Clinician sets the agenda to patient sets the agenda. So think about the typical clinical encounter. If you actually use something like that patient activation tool to tailor your information, to tailor your self-management support, based on where that patient's even at in terms of their level of activation. That's what it means by setting the agenda. We're teaching in the patient-reported outcome work we're doing around how to set the agenda around patient-reported outcomes and setting the agenda for goal setting and action planning related to that. We've only just touched the surface on that. Again, the goal is compliance, changing that to enhanced confidence. So we've armed some of the disease psych clinics in the IP study to actually use confidence rulers, commitment rulers, to see how confident patients are in managing particular symptoms when being given advice. And of course, decisions made collaboratively. I won't spend a lot of time describing this model, but right down at that clinical level, this is the model that was put forth as what's called the 5 A's model. It's been put forth in the guideline, the RNO, the Registered Nurses Association of Ontario guideline for self-management support of patients. And it's a way of actually putting the sort of self-management counseling coaching approach right within your clinical encounter in a very easy, rapid, and easy way. And I can share a lot of this, but it's really about setting that action plan. It's really being able to explore and assess the patient, where are they at, set the agenda with them, set the goals and action plans around the things that they need to actually adopt behaviors or self-management behaviors around. Building their skill sets around problem solving, again, by asking them about barriers to managing, barriers to enacting the behaviors you've just taught them as an example, and then arranging for follow-up support and rearranging when you'll see them again and help them to work this through. And we can speak to this more in depth. The other thing that we start to think about is maybe we need to think about a stepped approach for self-management support as well, but starting with the whole issue of, are all of our materials, and I'm sure they are addressing the issues of health literacy, that they really are focused on structured in such a way that they actually tell very clearly to the patient the behaviors or actions that they can take to manage a symptom. What I find is a lot of materials are very self-care oriented. They have a whole list of things that the patient can do, but there's no structure to them. So the patient doesn't know, if I take this action, will that be the most important action to maintain or deal with this particular problem? Or they'll be structured in such a way, it'll say, here's all the self-care activities, or contact your healthcare professional. So again, patients aren't really clear, what's the action I can take that's going to make that difference in managing this particular problem. So starting to think about our materials in terms of, are they actually written and tailored in such a way that they're actually framed in activation terms for patients? And then maybe we start to think about behavior change support that's really about goal setting and moving up that train to much more advanced health coaching approaches for self-management. That might be required for some of the population. It may not be required for all the population. So we may want to start to think about, what are the core skills, the core standards of knowledge and skills that we want staff to have to be able to be effective coaches of self-management on a routine basis? And where do you step the patient up to the next level of required self-management support based on the complexity that they're dealing with, based on the amount of self-management behaviors they're going to need to adopt, and of course, their level of activation might be important to think about. In the co-creating health that we're hoping to replicate here at a few sites within Ontario, what they showed is, again, there is a whole system approach that's required to actually shift self-management support to become a standard of care. And in the co-creating health program, what they showed is that advanced training of clinical teams is required, that all clinical teams will need to be exposed to some kind of training within self-management or self-management coaching skills. Self-management support patient programs need to be available, that patients, and I know patient education is working on some of this as well as Elixir, that those self-management support patient programs are available, and recognizing that, of course, patients can attend community programs right now, chronic disease self-management, that will teach them some of those core 5 skills, problem solving, decision making, goal setting, action planning, but they may not be as specific to cancer and the needs of that patient population in terms of the disease-specific issues. And then the final one is service improvement or program and system change that's required to shift the model of care. So if you have to follow up to determine whether a patient is actually absorbing information in the self-management, they're actually taking the actions on the self-management behavior, waiting until their next clinic visit may not be the best time. Maybe that's where the proactive approach that's coming into play in colorectal and breast, to be able to follow up with them around self-management behaviors in a more timely fashion throughout that course of their treatment cycles may become incredibly important. So to wrap up, so I can leave some time for questions, is self-management, of course, is a really important and powerful resource that I think is significantly underutilized. It's specifically, particularly within cancer populations, we've got a long way to go to sort of transform the model of care and how we're actually working with patients and around managing their illness. And of course, it's fundamental, but it is often the least utilized aspect of personalized cancer medicine that we need to think about and becomes important to think about from our perspective. So that was a lot of information. Questions, comments, time for dialogue.